Hello and welcome back for episode 37 of the Noobie Dentist Podcast. I'm your host, Dr. Omid Azami. It's been a few weeks since the last episode, and I'm going to stay on trend with the implant topics. The last interview, we interviewed Sydney-based general dentist, Dr. David Attia, who's doing a lot of work with soft tissue and implants. And actually, he introduced me to today's guest, who is Dr. Philip Walton out of Toronto, Canada, who's a periodontist there. And, he came with high recommendations as being a really humble and, fantastic and caring individual who really loves periodontology and has become very active on Instagram and is, contributing a lot of great content to the dental community that we have on there. As you know, the Noobie Dentist Podcast is, mostly based on Instagram. And when I meet people who are such positive members of that Instagram dental community, it's always a pleasure to talk to them and see their journey and their pathway. Dr. Walton is one of those people that, when you read their resume, you kind of feel bad about yourself. But, he's just a truly humble and genuine guy, and I really enjoyed our chat. Dr. Walton went to the University of Toronto Dental School, where he completed his DDS, and later on he moved on to Harvard to complete his periodontology specialty. He's been out for about 10 years now and working in private practice in Toronto, Canada, and doing some really innovative work in some of the practices that he's working at, centered around same-day implants and temporary tooth replacement. We chat about a lot of topics, including, pathways into implant dentistry, the role of social media and Instagram into dentistry today, and how it's, helping, general dentists, dental students, and even specialists, accelerate their learning curve and progress in their specialties and in their careers. I really enjoyed this chat. It's nice to hear the Canadian accent. I must apologize. The audio quality is a little bit choppy at times. My internet wasn't the best on the day. I have since upgraded my internet at home, so hopefully the future episodes will be a little bit better in terms of how choppy they are. So just bear with us. There's a lot of fantastic content on here, and I hope you guys enjoy this episode and get as much value from it as I did. As always, you can find me at Noobie Dentist on Instagram. Reach out with any questions or comments or feedback. I do love to hear from you guys. The podcast is available everywhere on iTunes, on Stitcher, on SoundCloud, on Spotify, and also on my website at newbiedentist.com. If you have any positive feedback, if you can rate us on iTunes, that is fantastic, and it would help the community grow. The interview was so captivating that I actually, we just fell into conversation and I didn't have a formal starting point. So if you don't mind, we're just going to jump into the middle of the conversation from where we kind of kicked off things and take it from there. Without further ado, I hope you enjoyed this fantastic episode with Dr. Philip Walton, a periodontist out of Toronto, Canada.
Hello and welcome to the Noobie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Noobie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Azami.
As a result, he put me in touch with a periodontist who at the time was the head of Perio and the head of Mount Sinai. Howard Tenenbaum is his name.
Yeah.
And I basically would go every Thursday night after dental school to go shadow this guy. And essentially, I would spend my evenings watching him. And as a result of the relationship that I forged with this Dr. Tenenbaum, who was a pretty big deal in the Perio world, he ended up becoming like, he wanted me to go to Perio, then I wanted to go to Perio because of it, and he was my letter of, the letters of recommendation, and kind of was the whole thing. So Bruce, in some ways, is at least in part responsible not only for becoming a periodontist, but then on the back end, he also was responsible for helping hook me up with a number of the jobs that I currently have. So
yeah, that's awesome. So you just started like your own practice in Toronto, is that right?
No, so actually quite the opposite.
Yeah.
I don't have my own practice. I actually finished my residency. I went to Harvard. I finished in 2011. Yeah. So I'm coming on like 8 years now, basically, come May. And actually it was Bruce as well, who at the time, he kind of initially discouraged me from starting my own practice. Mm-hmm. And I always thought of myself as an individual who would 100% personality-wise, etc. I want to set up a big practice, Yorkville, center of the city, be like the kind of guy. Yeah. And when I first came back, Bruce's suggestion was that he thought that the topography in the field was changing. and that not that there wasn't a place for external referral, typical specialization, but there was a lot of factors coming into play that he thought you should at least just try, maybe consider working in a couple of solid GP offices. You have a lot of debt, like everyone, and coming from Boston was like crazy, like it was hundreds of thousands of dollars. And he said, maybe before sinking yourself another $1.5 million into debt without knowing for sure that's what you want to do and establishing a practice, get your hands dirty, establish a bit of a reputation, etc. So I did that. I also paired up with a periodontist at the time who was a bit of a controversial personality in the city, but very successful. And a lot of people told me I shouldn't, but I guess sometimes people need to learn the hard way, and sometimes I'm one of those people. And as a result, we broke apart pretty quickly after like 7 months. But I think I was a little bit like a guy who came out of a bad relationship. I felt like a little bit scorched. So I just, you know what? Not for me. I think I'm going to continue putting my head down and just working at a number of these GP offices. That whittled down over time from being like, initially I was working at nearly a dozen practices all over town. Brantford, an hour outside of the city, Barrie, you name it, the East, Durham, etc., Oshawa. And then over time, fortunately, I was able to kind of pair myself up with stronger, practices that were really more in line with how I wanted to be practicing. But even still today, I actually practice at 4 practices, one of which is basically my home base. And that's probably if you ever are following on Instagram or seeing these bigger surgical cases that I'm doing, it's kind of like an implant center with several surgeons, a couple of oral surgeons, myself, a periodontist, and a couple of general dentists who exclusively practice implant-related care.
That's awesome.
But that's so that's kind of, I guess, in a nutshell, kind of where I'm at professionally.
And is that in the city, or where's that one?
So it's actually close to York University. So it's it's just, technically GTA. But from the heart of the city, 15, 20 minutes. But we moved. We were at Yonge and Sheppard, even closer to the city. But a good problem to have. We were a 5-operatory, couple thousand square foot space bursting at the seams. We had close to 30 staff and no place for people to park even at that area of the city.
That's a tough area
really
to find
needed
parking.
a bigger location.
That's
cool.
Cool.
It was a big complaint, especially for some of these longer appointments where people were being sedated and being picked up and whatnot. So we purchased this building, which was actually an old jewelry manufacturer, and it's huge. It's 30,000 square feet. And it's just, I've a couple of years in the process, just finished up, and we moved in November, but it's a whole different beast. It's 18 operatories.
Wow.
Scale labs, one just for doing these full arch reconstructions where we have denturists working, one for doing all porcelain and single tooth restorations. It has a full amphitheater basically for continuing education with like breakout rooms, a full kitchen for catering to that stuff.
Wow, nice.
And like a waiting area that's like the size of like an airport terminal. It's like a little crazy, but it's a really special practice. It's a little bit of a one of a kind as far as we know, even in like for sure in North America, but it's a really cool, it's a very different kind of environment.
Yeah. And you don't have so is it who owns that? Is it just the couple of oral surgeons that own that, or?
Yeah. So actually, interestingly enough, the guy who owns it is a general dentist. And he started off years ago very into implants. And he kind of dedicated his practice saying, I want to be an implant guy. And all he did was place implants. And he was really struggling to establish himself. Obviously, to get referrals from surgeons or dentists to a general dentist is challenging. So the way he just kind of, I guess, differentiated himself was to actually really try and push like same day dental implants, which you hear about in advertisements and see on TV and whatnot. But basically he, for both full arch reconstructions where you kind of, edentulate a person and put in implants and put the teeth in the same time, but also for single and multiple, that's kind of our thing. But to do it and to do it well, a lot of people are under the misconception that it's like just not possible. You have to go the conventional route. You can, but you need a crazy infrastructure. So it was his dream to always build this thing, and it just took a fair amount of balls and money to do so, and a vision. But he's a visionary guy.
That's
and
awesome.
Basically, you need to have a lab, and you need to have dentists, and you need to have surgeons, and you need to have everyone kind of be on the same kind of field. So that's kind of my home base, and I'm there a couple days a week, and then the other few days of the week I actually spend at at general practitioners' offices.
Okay, cool. And is it just pretty exclusively implants, or are you doing like a wide range of perio treatment?
Yeah. So at that clinic specifically, 95% of what I do are dental implants, and we push out a lot of them. And we push it to the limit in terms of like the way that we're been so successful in actually gaining our referrals in spite of the, I guess now being a little more challenging in a very dense and saturated city, has to do with the same day care. So whereas a dentist may decide to send to their typical periodontist or surgeon who will tell the patient, I'm going to take the tooth out, I'm going to bone graft, you're going to wait 4 to 6 months, then you're going to come back, I'm going to do a second procedure, then you're going to wear a flipper for another 6 months, and then we'll give you a tooth.
Yeah.
Strong contrast to, well, we know these guys who you're going to go there and they're going to take the tooth out, put the implant in, and give you a tooth all on the same day.
Yeah.
So as a result, we've really, really, really grown quite steadily from basically a few years ago where we weren't even working with referrals. We were just direct to consumer with marketing and stuff, to actually ramping things up to the point where we have, like nearly 700 or 800 active referring dentists who really work with us on a big basis. And we get a lot of word of mouth and things like that. But I guess back to the combination of this practice, how it succeeded and why I didn't start my practice. Some of the big factors, and what I was telling you about with perio in general, how it's changed, and I think just specialization in general, is that, perio has suffered in a couple of ways, unfortunately. One is guys like me are guilty of the sin of going in-house. Yeah. And as a result, you've got your guy who used to send out no longer sending out. Yeah. The second is that a lot of general dentists, as you know, both abroad and here, are learning dental implants and periodontal surgeries, whether they're taking extensive courses or mentorships or observerships, and really incorporating that stuff into their practice, especially with the degree of, I guess, with debt and whatnot. People want to be able to do all sorts of treatment. Yeah,
it's changing a lot for sure.
Yeah. So, and then the last piece is that with corporatization of dentistry, where these big corporations are buying dental offices, the first thing they do is they're like, stop sending your hygiene out to a periodontist. We're going to keep all that in the practice. So between all those things, it's made it a little more challenging, I think, for your typical external referral. They still exist. There's still guys who are extremely successful at it, but that's what kind of drove me to do what I've been doing.
That's awesome. So I think that makes sense, and it works out quite well for you guys because your overhead is obviously pretty much nothing, because you just have like this sort of like an associateship model where you just pay a small percentage, and it's probably a better deal than what general dentist associates kind of get as well, I'm sure. So what's the non-surgical perio treatment, like the basic stuff that you kind of learn in dental school and things like that? Where is that now? Is that just like all in the hands of hygiene? Like who's managing these like chronic perio diseases and things like that?
It's a great question. So, and this is something I was actually discussing recently with some colleagues as well. So I think one of the biggest challenges that I think a lot of periodontists and perhaps, and certainly myself, are guilty of is that there seems to be this drive towards prescription kind of surgery. So we're doing like these treatments, but it seems like it's getting harder and harder to actually manage your typical chronic type of perios. I mean, the AAP has recently changed the way that we diagnose perio, and it's actually a little bit confusing. But what was your formerly generalized chronic severe periodontal type of patient with 4 to 5 millimeter pockets, etc. Those patients, for the most part, typically the practice that I work in, I have a periodontal program instituted where we know, based on people's presentations, radiographic bone loss, probing depth, clinical attachment loss, recession, etc., and their systemic issues, whether they should fall into a 3-month, 4-month, or 6-month kind of maintenance protocol. Yeah. But for the most part, they do actually deal with the hygienist. And only if something changes amongst doing their periodontal charting, whether it's annually or semi-annually, we see progressive disease or symptoms that develop, will they end up back in my chair for a discussion. So I think your everyday person, whether diseased or not, will either just be getting increased frequency of care from the hygiene. Yeah. That may be being done in the general dental office. It may, if it's an older model, being sent to the periodontist, to their hygienist. But essentially, I think for me, if a patient ends up under my care initially, we typically go from your usual phase 1 to doing like a so-called deep scaling and root planing. It would be the first thing for someone who has deeper persistent pockets with local anesthetic.
Yeah.
We reevaluate it, and then they may end up getting types of flap surgeries, or certain people are doing laser surgery or laser procedures like LANAP, for instance.
Yeah.
But for the most part, I guess the short answer is that the hygienists are actually rendering the care, but a periodontist or the dentist would be the one who's supervising, or the so-called responsible provider dictating how that care is given.
That's pretty cool. So I didn't know that. So even, traditionally, if you would refer off these cases to a perio, it wouldn't be the actual perio doing it. It'd be a hygienist in the perio office doing it.
So you can't really, so it's the hygienists that are doing all the scaling and everything.
Yeah.
You're not a periodontist. There are some old school dentists, some really guys who were like one operatory, et cetera.
Yeah.
Sometimes you may be able to find some periodontists. Honestly, I bet you that vintage is probably like mid 70-ish age bracket now, like kind of very tail end of their career, who are doing it. But for the most part, you have well-trained hygienists who are experienced, who are fantastic doing that, and then just kind of, I guess, collaborating with the periodontist to make sure that things are stable, or if they look for any type of direction.
Yeah. So in terms of, periodontal training, like here in Australia, Melbourne, when I went to dental school, it was pretty much just like scaling and root planing, and, with quadrants with LA and things like that. We never really were taught like surgical, like flaps and things like that, just to like do that. So what's it like in Toronto where you did your dental school in terms of the perio education and exposure clinically?
Yeah. So I think for the most part, it's pretty similar. At least it was when I was there. And I remember that was definitely, at U of T in general, I think one of the kind of the reputation it has, and one of the biggest challenges is the amount of clinical work that people actually get under their belt when they're there. It's kind of famous for its academia and its research and its didactic portion. But, especially even in comparison to Western or other places, you don't necessarily hit the pavement with clinical as early. From a perio perspective, I remember we were placed as assistants in the post-grad perio to actually observe and assist for some of the surgeries that they were doing. And we were allowed to do very, with permission and a lot of steps and kind of paperwork and whatnot, everything at U of T. You could do some very basic type of perio surgeries, things like a flap if it was like confined to a sextant or something like that. Mm-hmm. I think just maybe flap and maybe crown lengthening. Those may have been the only procedures. No gum grafting, certainly not dental implants. So it was quite limited. And I remember I was very fortunate. I got to do one, which was that was crazy at the time. That I to arrange it with one of the perio postdocs and with the chair of perio. But for the most part, like you said, it was really limited. And it's funny. I don't know if it's good or bad. In some ways, I guess advantageous to me, because then maybe people aren't as comfortable. They need to learn after the fact, and they'll also feel the need to send. But it's also a little bit of a shame, because how do you necessarily really know that you want to pursue something?
Exactly.
And if you want to do something, you have little to no experience in it, which is also a bit of a nuisance, of course.
Yeah. So so I know, we were talking earlier and you said you had that exposure to perio and the chair of perio at one of the hospitals there in Toronto. That kind of swayed you towards doing perio as a specialty. Were you ever considering any other specialty at all, like during your dental school days?
Yeah, I think like you. So for me, as silly as it sounds, there's these people you meet the first day of dental school, and they know exactly what they're doing, right? They're I'm going to honest, I know, right? Yeah. And at first, I was kind of hard on some of those people, how the hell do they know? But then you realize that even through dental school, you don't necessarily get to do that much of a procedure. So you have a choice. You can be like the person who says, I'm going to graduate, I'm going to work, I'm going to do residency and gain more experience. Or I'm going to kind of in my head, craft this idea of what I think is attractive to me. And I think even with dentistry as a profession, none of us picked up a drill before we decided to be a dentist. We said, maybe my dad was a dentist, my friend's a dentist, good profession, you can make a good living. It's kind of like being a doctor, etc. Blend of art and science, that business.
Yeah.
It was, the idea of surgery was very attractive.
Yeah.
I loved the idea of surgery. So it was either oral surgery or perio.
Yeah.
And, as silly as it sounds, in it, oral surgery is more years. And a lot of guys said to me, it's more intense. and it's like the residency is call hours and your life could be call hours. And a lot of them actually told me that, surgeons that I knew, they're like, I went through all that, repairing faces, LaFord fractures, all this cool stuff. And then here I am, and in the end of just popping out wisdom teeth anyways. So not to say that's every oral surgeon by any means. I'm sure someone will hassle me about that. But so for me, I also, and then I guess the last driving thing was I really liked, I like precision versus like gross. So I think when you think oral surgeon, not that every oral surgeon is like that, they're doing larger scale, facial trauma, wiring jaws, bigger procedures. And I really like the meticulous nature of the small. We're using 7.0 sutures now, 8.0 sutures, microscopic plastic surgery. And that was a bit of a draw for me. So I think that kind of guided me. And then plus the mentorship and everything like that.
Yeah, that's pretty cool. Yeah, it's crazy. Like in Australia here, the oral the oral maxillofacial surgery, pathway, it's more like the British model. So like you do your dental school and then you go into med school. You gotta do all of med school. It's not like the American 6 years sort of blended programs that we have in North America. So people here, it takes them almost 10 years to become a max fax. And obviously because of the backlog of specialists and things like that, there's not that many hospital jobs that you're doing these cool LaFort fractures and doing the orthognathic surgery and things like that. So they end up doing school and training for 10 plus years, and then they just come back and they're taking out wisdom teeth and doing implants. So I always thought, I'm that's a little overkill. So I like at least in North America, the oral surgery OMFS, there's the 4-year version and the 6-year version. Seems a little bit more reasonable to do to get into those pathways. Perio is cool. I think perio obviously is a lot, even with probably my next question is going to be with implants, because the periodontists are doing implants, prosthodontists are doing implants, general dentists are doing implants, oral surgeons. So what's as a general dentist, if I'm going to be referring a case out, how do I decide who the best person is in terms of their skill set or their ideas of management?
Periodontist, obviously, right? No. Not even close. Actually, you know what? I think so much of it, obviously, a lot of it has to do with your relationship with the person. And you obviously want to send to someone who you think is skilled and talented. But a lot of the times when you look at people, for right or for wrong, that the way their referral bases were set up, whereas a guy they were in school with, a guy they play hockey with, a guy they drink beers with, they golf with, whatever, they still think that person is good, but there has to be a trusting relationship. I think one thing we've benefited from, and what I hear from my referrals, is that perio has this reputation that we pay a little closer attention to the soft tissue management. So, whether there's any truth to that or not, listen, I can show you a million periodontists who don't, and a number of oral surgeons who do. So I think that even though it's a generalization, I think it's worked to our benefit as a field. And that a lot of people think, if it's a posterior case, I can send it to an oral surgeon. If it's an anterior case where the critics are more important, maybe I need to send it to a periodontist. Maybe it needs a little gum grafting or something like this. I think you hit on a very good point, which is that everyone and their brother are placing dental implants. GPs, prosthodontists, endodontists these days are placing implants. And you know what? I'm not against any of it. I think it's just all based on people have different levels of training. And as long as the person that you're sending to, you feel comfortable with their background, with their training, you can certainly see people's work through either lecturing. Instagram dentistry really is in some ways the future, how it really has changed. It's just made the world so small. Like me talking to you, talking to David, treatment planning with him. I have a guy who's currently visiting and has been for the last 2 months from Turkey, at our clinic. It really is it's a game changer. And I think it's a really cool medium, even though I thought it was really strictly for 13-year-old girls.
When did you get into it?
Honestly, I have to tell you that it was just the summer, and I wasn't really on Instagram at all, period, even personally, besides my wife bugging me to post a picture of our kid or something so someone could see it. And my wife was on it. I thought she was just fooling around. She's an interior designer. She said she was always working. She said, I'm on Instagram, I'm working. I said, what are you talking about? That's ridiculous. And I guess Instagram knows everything about you, and so does social media. So certain big dentists and surgeons started showing up in my feed. And as a result, I added them, and I actually started asking questions. And to my total dismay, some of these big guys in the world actually were writing back to my questions and comments. What suture are you using? I'm using polypropylene. Or what incision design was that? And I was like, some guys didn't write back to me because they said you're a private thing, and we don't know, you're a private whatever. So I started a professional account. I think it was in like July or August. And I full out became like, in some ways, addicted to it, because I have learned so much from so many people of varying levels of experience and expertise, and tried new procedures because of it. And I mean, I've established amazing relationships, visiting guys from kind of meeting huge guys from all over the world, meeting people over the world, having people visit here. It's really established a cool network and collaboration. And I think it also holds me to a higher level, because when I post stuff and when I've gotten back to taking photos now, which I didn't used to do, there's a lot more accountability. You see your photos and you realize maybe you weren't as happy with that case as you thought you were. And these are the little things you could have changed. And also, every time I do something now, I think, would this be something I'd want to put on Instagram for, thousands and thousands of people to see? Is it good enough quality? I think one niche that I have that we spoke about is that I really, for me, not that I was trying to have a brand or anything, I just want to be a humble, accessible guy who has the same complications, trials and tribulations as the most experienced, the least experienced, whatever. I mean, the patient difficulties from dialogues to treatment planning to communications to failures, etc. So it's been really good in that respect. And now I get a lot of messages and whatnot, just kind of bantering with people from all over the world. So it's really including yourself. So I think it really is in some way, I don't know how, but like the future of continuing education.
It's been amazing. Like during dental school, I started, like, the first account I started following was like Bloody Tooth Guy. And he's like the oral surgeon, like in New York. I was obsessed with him, and that's like
followers.
Yeah, he's huge. And, I think it was like in third year, fourth year dental school. So, and, I wasn't doing much. So I told you I was like, I really, really into like oral surgery and stuff. So every time I was like taking teeth out, I was like posting it, and all my friends and classmates were like, what is this? So they started eventually doing it, and it kind of caught on. And then I remember, this is like on my personal account. So like all my high school friends were like, what is this like random like teeth you're like posting and stuff? So he started following me, and I was like, I remember I took a screenshot. I was like, man, it's like the best day of my life. Like Bloody Tooth Guys like following me. So yeah, when I graduated and I sort of started working, and I kind of had the idea of like starting a podcast and all that, I was like, okay, so I'll do the Noobie Dentist thing. Just like, again, like I think, like you said, being humble is like pretty cool. And, now that, I've only been out for a few years, I'm like slowly getting better, and like I'm posting like better quality pictures and stuff. But it's like always cool to like look back and scroll through and like see like the crap I was sort of doing early on. But you hit the nail on the head. I think when you go into like a procedure, and for us, if we use like big implant cases, for me, it might just be like a simple class 2 or something. I was like, no, I want this to be perfect because I want to post it, and it makes your dentistry better. So I think it's like a sweet cycle that people are in now. And like you said, the networking and the collaboration and the mentorship. Like you said, I have a simple clinical question like, oh, how do I do this margin? I can message a prosthodontist in New York or in England, and they'll get back to you. It's like insane.
Yeah. Do you find, is the younger generation, but like I get messages from people, I'm in second year dental school. I'm thinking about doing perio, whatever. But is it, I guess, in dental school, if I was in dental school or if I was in my residency, I feel like I would be like beyond into this. So do you find that a lot of younger dentists and clinicians and students and residents and stuff are like really using Instagram as like a tool for like not only learning, but like finding continuing education and things like that? Because people ask me like, what like a lot of my friends are like, so what's the purpose of what you're doing? They're like, and I'm like, you know what? Yeah. I really enjoy it. It's almost like a side hobby. And I also think I'm growing my career and whatnot. But I mean, ultimately, people do ask me, can I come learn with you? Can I come to the clinic? So there could be something there in that respect. That wasn't the intention. It's just an indirect thing. But I'm curious to know, like, I guess, is it really like a mainstream kind of thing now? Because for me, it was an undiscovered world. I didn't even know this existed 6 months ago. And now when I lecture, I talk about it. And most of the audience who, is 40, 50 plus is like, what are you even talking about? And then they'll come back from the break and be like, whoa. Like, this is Spear Education is on here. Like, Sasha Jovanovic is on here. Like, every guy is on here doing stuff. Like, this is like for real.
Yeah. So I think there's that, like that was like the theory of like diffusion of innovation and things like that. It takes time to trickle down to the elderly demographics. Sure. I think people in their like 40s and 50s, like they're just now on Facebook and they have like their Facebook groups and like people post cases and stuff on there. I think Instagram, like you said, they probably saw their like teenage daughters and sons on there and they haven't thought about it much. But I think people our age, like the millennials, are pretty active on Instagram. And I think for specialists, I've talked to a few specialists in the city in Melbourne when I moved back, it's like a great marketing ploy, right? Because
Sure.
one is you make yourself more accessible than the 50-year-old down the road who you've never spoken to. And two is like, if you're actually having that relationship and that interaction and the dialogue and going back and forth on cases, I could even like start a case and you've kind of helped me plan it, and I kind of get through it, and I'm like, you know what, it's a little bit beyond my scope. And then I send it over, and you already know what I'm talking about. You know what the case has been. So I think it's already there. I think it's going to get more, widely used. I think it's, the dentists and the dental students who use Instagram for these purposes are the same as the ones that listen to podcasts. Like a little bit of a self-selective group of people who are like trying to be better all the time. Because a lot of people, just kind of cruising through and they're happy with status quo and how they're doing it. But so I think it is a little bit of a selective group, which is fine. I think at least it allows an avenue for people who want to get better to get better.
It takes effort out of my day, like to be posting everything, the amount of surgery I'm doing and posting it and trying to respond to everyone who messages me. It's a huge amount of effort, but it's I find it to be, I learn a ton from the questions that I have to field. And I learn, fortunately, I find that people are pretty informationally generous on Instagram. There's something about the person being another world away or whatever away that makes like there's less of a guard or a defense up, where like people don't mind saying like, this is how I did it, or here's my secret sauce or whatever. Like I've always been very like that, even in person with people. Like I don't really have anything to hide. I feel like if I can help someone, it's great. But I think that the Instagram thing is totally wild. Like I work pretty hard at it. But it gives a lot to me as well. Like as weird as that sounds, and we always joke amongst a lot of the bigger guys who, I follow and now kind of friends with that it's like social media seems antisocial, but actually I've never felt more connected to these individuals.
That's awesome. And so what's your tip for general dentists now? Like, you've been graduate for, 1 or 2 years, and we're like, oh, we like surgery. We like taking teeth out. We like, doing wisdom teeth and stuff now, tackling some cases. What's a good pathway? Obviously, let's speak from the North American side of things, because you're obviously there now, so you might be more familiar with the training programs and courses and things. What's a good, responsible pathway for a general dentist to kind of get into placing some implants, and also like covering themselves a little bit, because you don't want to be cowboys out there and getting into trouble. So tell me a little bit about what you've heard or what you've seen from general dentists who have been pretty successful in doing implants, and how there's kind of came to that point in their careers.
Yeah. I mean, you look at a lot of guys who are general dentists who are fantastic. The guy that I mentioned who kind of started this clinic is, he places more implants a year than probably any periodontist or oral surgeon in the city. So he gets good at it. Now, how you get to that point without feeling like you're a cowboy is a challenge. I mean, the easiest but not easiest thing to do is, of course, to take like a typical residency, but that means, X years of your life and a lot of money and whatnot. But I think if you want to just incorporate implants or anything into your practice, you start with basic either mini residencies or Cs or things like this. And you've got, I think the biggest challenge is trying to find the ones that are actually high quality, because you can be inundated, whether it's social media or, mail outs, whatever it is, about these different programs. There are great ones in many different areas. Like our clinic runs, like we have a faculty that runs, an implant residency. I think really trying to get on the continuing education train is really important. And then I think that the biggest piece that comes with that, from like the so-called cowboy aspect, is that, I mean, I think when you enter, like anything, you have to just feel comfortable working within the scope of your practice and whatever it is that you're taking on. Of course, there's always a leap when it's something you've never done before. And listen, I'm learning every day new things that I didn't learn in my residency, and I only graduated within a decade, of which I thought was cutting edge. And it's can be absolutely scary to try and incorporate these new things, even as a relatively experienced clinician. Surrounding yourself with good mentors is a good thing as well. So I think Instagram is interesting in that respect. Not that that's how you, but asking people or having someone as a backup. Like my dad is a GP, and he sends his CT scans to me to make sure there's nothing he's missing before he takes on doing his basic 3/6 molar implant with a nice wide ridge. just wants to make sure, right? Like, it's like, or he knows that he has me as a backup, not that that's how he's working, but God forbid something happens. And that's where those relationships come into play. I think like study clubs and things like that are helpful, but I think just getting yourself really into a number of kind of CE type of situations would be good, with at least the basics of like a foundational kind of, a lot of these people call them, like I said, mini residencies, where you do get a lot of hours and like you can have someone over your shoulder. One cool thing, and part of the reason our clinic is so big and what we're trying to get into, is started off giving didactic lectures, and then we've turned it into hands-on components as well, where you can bring your own patients and whatnot. But we're trying to create these kind of apprenticeships or observership things where even after that, you could physically just bring your one patient and schedule to have Dr. Walton or whatever surgeons there not only treatment plan it with you in advance, but be over your shoulder for the case. We can help you like provide the instrumentation in case you don't want to sink the overhead right off the bat and things like that. It's almost like a rent-a-dent. Like you can come and there's a menu of, I want the chair, I want the assistant, implant inventory, I want the anesthesia.
That's a great option. Yeah,
it is. So it's a pretty cool thing, and we're just kind of in the infancy of it. But I think that's a great way to really gain comfort. And then of course, just time and experience, starting slow and just easing your way in, as opposed to just going right at the, the most like biggest case, because you have a lot of debt, right? I mean, that's where you never want to be.
Yeah, exactly. That's awesome. So in terms of, the implant world now, as a general dentist, what's like, so you're saying is the most routine cases, what would be like a good starting, like, so if you say, so you've done your courses and everything, you're like, okay, I want to start getting my hands wet and doing some courses. What are some of the case types or teeth replacements that you recommend as like a good starting point?
Probably just a posterior tooth is probably not that it's like you want to do any worse in the posterior area, but the stakes aren't right. And I've seen unfortunately the outcomes of the best intention, loveliest guys trying to get started, and just didn't realize some of the possible complications that could ensue from doing a central incisor, placing it just a little bit too buccal, and all of a sudden the tooth is times and a half the length that it was supposed to be. So I would say just starting off with 3.6, 3.5, like a second premolar molar type of site, either mandible or maxilla, and then make sure that the area has adequate bony housing. And the easiest way to do that is just to send for a CT scan. I think the interesting thing is that digital dentistry and guided implant dentistry, whereas it used to be a thing that was only used in complicated cases near the nerve, near the sinus, close to like in congenitally missing lateral, that like the roots were converging. Now it's becoming more and more routine. A double-edged sword, because you've got beginner or novice clinicians who are learning implants, almost learning this out of the gate, because you can plan everything on the computer, and then literally, not like you're a robot, but you go and you do it, and it's a great thing, but they don't necessarily have a backup plan if something goes wrong or the stent doesn't fit perfectly. So I think doing things planning, like digital aided, as opposed to necessarily digitally fully guided, is a great thing. Going through the motions of plunking the implant in on the CT scan, appreciating the angle and the person's bite and everything, the anatomy, and then having it to at least start with your first drill and things like that to make sure you got the right orientation, angulation, and whatnot is key. And obviously, I guess a non-smoker, a systemically healthy patient, all these external factors are a great thing as well.
Yeah. So are you doing most of your cases like freehand, or are you doing guided for a lot of them?
So it's a really interesting kind of evolution, and you talk about change. So I did a pretty small amount of guided in my residency. I had a not so great experience, but things have changed drastically. I actually did a lot of what was at the time called Nobel Guide, and it was like Nobel Biocare's brand name kind of guide. It was for doing arches, and I was doing like 8 to 10 implants, and we were doing them like flapless and just plunking them in. And as a part of our follow-up protocol at the school, before I left, we had to take CT scans of these patients. And a lot of the implants were not where the guide had shown them to be. They were somewhat out of the housing, wrong angulations. So I shied away. And then for a long time, I kind of felt like I wanted to be like, the most skilled clinician, the most talented, the most accurate. And I to a degree so much that I think I fought the digital world, saying, that's for people who, they don't have the experience, they don't know what they're doing. But
Yeah.
you know what? I'll tell you that done properly, it's an amazing adjunct, and I'm slowly coming around to, I think it took a little bit of almost like biting my pride or some courage to say, you know what, probably even with the degree of error that's introduced into these digital things, this is a way for me to be even better. And that planning things in advance and noticing things in advance and making sure the implant is perfectly through the cingulum where you want it and just on the right prosthetically driven position, and you know that multiple implants are spaced properly and not near any anatomy or anything like that. It's really growing, and I'm using it more and more, and I'm trying to use it, I don't want to say for every case by any means, but it's definitely the future, and certainly for a lot of clinicians already the present.
Yeah. So you mentioned earlier, like, you know, one of your differentiating factors in your practice and how you guys are modeling how your things are doing is like the same day implant in tooth. Obviously, like when you go, you know, we're going through dental school and even like in some of the CPD and stuff, you know, like you said, you got to, you know, place the implant, wait like 3-4 months for osseointegration, and then do another stage. Tell me a little bit about what protocol and like, how is it that you're doing what you're doing now? How is that working out?
Yeah. So the history there is interesting because when I graduated, I was of the same mindset, traditional delayed-ish protocol, take the tooth out, wait a few months, put the implant in, wait a few months, put the crown on. And actually I had heard rumblings of the clinic that I now work at, that they were doing stuff the same day. And when the dentist asked me my opinion, I basically told them that it was BS. There's no way. And when I told you that I was working with a periodontist, that I was at his office like 3 days a week, and we split and went our separate ways. Well, I was left with 3 days of nothing to do with my schedule. And I was a young guy and kind of scared, and like, I'm supposed to be a successful dentist and everything's supposed to happen. Here I am working 2 days a week, you know, living in my parents' basement, like what's going on? And I saw a flyer for this clinic. It's called Chrysalis. And on one of the dentists that I worked with desk saying, we're holding what was called like a dentist information night. Come, hear about what we do, hear how we do this stuff and whatnot. And I saw the doctor on it, and I was like, I kind of have heard of that doctor. And through like 2 degrees of separation, I was able to get his cell phone number. So I called this guy and said, listen, is there any way, you know, I'm a young periodontist, I'd love to come observe. I just want to come watch. Of course, in my head, the thought was, I need a job now. So I showed up there. He said, sure, you're welcome to come watch, but you may not like what you're going to see. And sure enough, you know, I got there and he said, you know, periodontists don't like this place because it goes against everything that they've learned and they've been taught. But there was some older oral surgeons at the time working there who were very experienced doing the same stuff. I thought to myself, okay, this place is putting in thousands of implants every year, and they're running a successful business. They can't not work. And so what happened was this guy said, listen, like, you know, you talk about being a cowboy, but he said, just try it. He said, have you ever done a case? And I had never done a case before. I had never even immediately placed it. I was doing immediate placement, but not immediate visualization. So I started off gently, like incorporating them, and then more and more, and then getting aggressive. And then I dialed back a little bit and found my sweet spot. Now, the key is that when you speak to anyone who kind of naysays or says like, you know, this is not possible and you can't get the success, the truth is that if the next question you ask them is, have you ever done a single case? They'll be like, and they'll say, I've never done one before. So I think the challenge is that you need to know, I think the greater barrier is having the infrastructure. So if you do this in a typical referral model, you have to take the tooth out, have the laboratory prepare something, send the patient with the like a gauze in their mouth in their car to the prosthodontist, who puts the temporary on, who figures out the temporary doesn't fit because there's a little bone in the way, who has to send it back to the surgeon. It's very inconvenient. But because of the infrastructure that we have with the lab and ourselves, and every surgery I do, I have a lab tech over my shoulder. Place it more deeply, place it left, place it right, mesial, distal, not this way, not that way enough, because they know exactly how they want the tooth to look. So one is the infrastructure, which comes at a large cost, and a lot of people are simply not willing to do that. If you do these things chair side, which I have with some of my other dentists, it takes a long time. There's very little money in it for the dentist, sadly. Like they charge a few $100s for this temporary that takes them 3 hours to kind of fabricate and fool around with. and it doesn't even look that great. And if you don't make it really nicely and smooth, especially subgingivally, you will end up with bone loss and inflammation and problems. So I think the biggest barrier is that protocol-wise for doing it, there is also a whole surgical armamentarium and technique sensitivity that comes with this and learning curve. The way that we place implants to make sure they're immediate, from the type of drilling sequences that we use, to the bone that we engage, to how we prepare the osteotomies to smaller size, to the type of implant systems that we use with their inherent designs with greater taper and more aggressive threads, and taking it out of occlusion, and all these little things to get high torque values and patient compliance. These are all key pieces of the puzzle. And the truth is that even after all of that, we do push the limit. But part of that is because patients really come to us because they want it same day. And the referring dentists now have come to expect it, for good or for bad. And they say, I can always send it to my old guy if you can't do it at the same time. So there's this fine balance between
a little pressure as well.
Pressure's on, but of course, patient safety and success is the key. There will be conversations we'll have with patients sometimes telling them, listen, it's not my ideal to actually temporize this because the implant didn't go in as tightly or there was some infection present, etc. And we have patients who say, fine, just go conservative, don't place the implant, or I'll wear a flipper or something. Or we'll just say, you know what, let's roll the dice. And, we pick up the slack of that. So we deal with probably more complications than your average clinic does because we're on that kind of cutting edge. But because of it, we get to be in an exciting place. Probably the most gratifying thing that I do are these treatments where patients who have either told they can't get implants or told it was going to take 2 years with grafting and hip grafting and all this stuff. And we say, you're going to be in and out of the chair in 4 hours or in an hour, single tooth. And they're just like, it's probably the closest life-changing thing that I get to do as a dentist or as a doctor.
That's really cool.
Which is awesome.
Yeah. So let's, from the human side of things, you mentioned you guys deal with a lot of complications, things like that. I know for like myself and like a lot of the young clinicians, when your stuff fails, you take it quite personally. It's quite hard on you, right? So coming from an environment where you're dealing with that kind of stuff a lot, because you're obviously, the inherent nature of how you're practicing is you're pushing the boundaries a little bit to try and achieve results. How was that for you when you first started out and some of your implants started failing? How was that like just emotionally and mentally like trying to cope with that?
Still depressing. You know that stat they say about like how dentists have the #1 suicide rate? No, honestly though,
I think physicians are one now, so we dropped down a peg, which is nice.
I don't know. All my friends that are dentists seem to be really happy. I don't know where that all came from. We love our hours. It's great. I'll tell you a couple of quick things that, I remember the first implants that I had fail happened, fortunately, my 3rd year of my residency, my last year of perio. And I remember, I'm a pretty positive kind of outgoing guy, and I was kind of just a little glum walking my way through the halls. And one of my attendings said to me, what's the matter? And I said, I just had my first 2 implants fail, thinking like I'd placed a few hundred at the time, on my way out of the doors, basically. And I said, I'm really upset. Like, I'm really disappointed. And he said, you just had your first 2 implants fail. He said, you haven't placed enough implants. So, and there's a lot of merit to that. I think that the biggest challenge is that, and another time that I had complications, I remember one dentist who, again, one of my attendings who saw me looking so upset, he just said, that makes you a good dentist. There's lots of guys who do stuff and then they don't care that it went wrong or that it's a problem. And I agree. I think probably the toughest challenge of our job is, I'll come home to my wife and say, I'm just feeling ill today. Kind of like when it rains, it pours. And, I've had a number of implants fail. I think a little bit like maybe mental illness or other things that have stigmas and weren't as spoken about, complications in dentistry is not something that you see people typically putting up on the big screen. And for that reason, it makes it even more challenging. One thing I try not to be, I should say, is this specialist who's kind of classically are considered to be on this pedestal and like, if I had done this, then I wouldn't have screwed it up and you screwed it up because you don't have experience. Well, you know what? I think that someone told me the definition of a specialist is someone who's made more mistakes in the field than anyone else. And I totally agree with that because, when you are pushing the limits or not even, when you're doing more complicated cases and you're doing more volume of cases, whether it's implants or anything else, you're going to have failures. I had someone reach out to me on Instagram recently and said, I always find that people enjoy when you share your failures. Like they say, it makes them feel better. Not that like misery likes company, but it's nice to know. And you're not alone, that this happens to people who have every level of experience. I think anyone who doesn't tell you otherwise is unrealistic. This guy was messaging me about a post on some big famous dentist guy's thing. And he said, wow, this guy does everything well. How do you think he does it so successfully every time? I said, well, he has his complications, big bone grafts and stuff like this. He says, really? He said, do you think he has this implant, his implants don't work or something? I said, are you kidding? I said, sometimes you do a basic gum graft and it doesn't work. Sometimes you do a basic filling and it doesn't work. I mean, of course, when he's doing these crazy surgeries, sometimes they don't work. But you're absolutely true. People are tainted. And I think probably one of the other big difficulties is that there's a huge dichotomy between medicine and dentistry when it comes to complications. When you go to a medical procedure, they tell you could die on the table, and that's acceptable. Or I always tell people, have you ever seen what a prosthetic limb looks like? But when we make an implant, I put it in, the patient sits there with the mirror saying it looks like it's a 0.5 millimeter too long than our other central incisor, and it's a failure. And, how can you do this? Well, it's a prosthetic. I mean, we do a pretty damn good job, and we stand behind the work that we do. Surgeons have complications in medicine a lot of the times. Sorry, I mean, it's just part of what happens. It's the human body. It's surgery. It just is what it is. So I think we really, as dentists, I like to think, put ourselves at a high pinnacle. There's a guy on who's a colleague of mine in Beverly Hills working on very high-end patients. His name's Kyle Stanley. And he actually on his Instagram feed speaks a lot about, he speaks a lot to the pressures and the stresses and the mental aspect and emotions and anxiety that come with dentistry. And it's a really, really good thing.
Okay, I'll have to check that one out.
Yeah,
I think especially in Canada where, the medicine side of things is like OHIP and people don't pay out of pocket. The expectation is different. Whereas they come into a dental office, like, I just paid like $5,000 for an implant. Why is it? Whereas if they go to a hospital, they don't know it costs the government or the system or their taxpayers like $50,000 or something to get like a knee replaced. But they don't compute it the same way, I think.
Look, you same thing. You walk into a hospital, you wait 4.5 hours to see the doctor. You're like happy to see them. Great, no problem. It took you 10 years to see them. You run 1 minute late in the chair, and the patient's like, what the hell is going on here? What's going on here? Let's go. What's happening?
Different expectations. Awesome stuff, man. It's been great chatting with you. Normally what I like to do is kind of just end these things with a bit of a rapid fire. So I'll get into that if you don't mind.
Yeah, go ahead.
So what's your favorite pizza topping?
Ooh, I'd have to go with, I really like a spicy salami.
Spicy salami?
Yeah.
Good choice. What's if you weren't doing dentistry, what career would you be in?
I think the smallest, maybe two answers to, if that's allowed. One,
sure.
I think sometimes when I'm doing surgery and I see other more significant surgeries, sometimes I love the idea of doing like plastic surgery or other surgeries like that. And like this tiny part of me wants to go back and like do medicine and do that and be like kind of on a bigger scale, or having a bigger impact on people. And the other thing that I just actually love just as a hobby is I'm very fond of watching real estate. Like I actually just enjoy seeing Toronto and being an interesting real estate market, looking at what things have sold for or buy for. It's just, I take interest in it.
Yeah. So it's like a completely different world. It's just
totally
going from surgery to real estate.
Totally different.
Well, I guess it's like making things over and making things look better and things like that, which is cool. So what's like the one procedure in dentistry, or I guess perio for you, that kind of makes you question your career choice?
I would have to say, so it's a bit of a double-edged sword again, but sometimes it's got to be implants, right? Just because the high degree of invasion with some of the cases and the stakes with some of the cases and the cost that people are paying and what they're going through, when you have complications with them, you lose sleep at night over it. I've been fortunate not to have any major ones, but you hear horror stories and those kind of things. When you're in those moments where things aren't going well, you think, boy, like money aside, everything aside, I'd pay someone to take this off my hands. It's very challenging. So I think complications associated with implant care or implant failures are probably the angst of my being. And as a young guy, doing implants at the quantity that I'm doing them now, I'm in some ways, I'm scared about what the future might hold for me 30 years from now. I'm going to certainly be seeing a lot of these people to my grave. So, the gum grafts and things like that, they work. They're easy. If they're complications, then they're easy to fix. Implants is a bit of a trickier twist. So I have a bit of, I guess, in some ways, a love-hate. Yeah.
And so since you're in Toronto, I guess let's quickly just wrap up with some sports talk. Like, do you follow like Raptors and Leafs a lot, or?
So funnily enough, I play a lot of sports. I'm not a diehard Leaf or Raptors or Jays fan. I'm quick to jump on the bandwagon when they're having good seasons. I'll always welcome an invitation to anyone who wants to, have me join them in their seats for a beer and catch a game. I'm certainly not the typical kind of diehard watch till, through all their bad and good type of seasons. But I play hockey at least once a week. I do a lot of sports myself, but I was never a huge sports follower, even as a kid. I don't know.
That's good. I think it's probably why you got so successful in your career. I think if I compute how much time I've wasted watching like soccer and basketball and hockey, like it's mind blowing. I'm like,
cool.
Yeah. Awesome, man. Thank you for coming on again. It's been great to chat with you. It's nice to hear that accent again as well, which is quite nice. I don't hear that in my day-to-day life. So.
Am I saying like a boot and how?
Yeah, for sure. It's like the way that like Torontonians speak, right? It's kind of cool just to kind of hear that again. So it's been fun chatting with you, and then hopefully we'll do another one in the future and kind of follow up and see how things are going with you.